Welcome to the Medical Muse podcast. Discover the humanistic aspects of physicians and scientists as they describe their career paths and any advice they have for current medical students. Each episode, we interview a new guest and discuss the future of the field. This is the Medical Muse.
Hey everyone, we have my father, Dr. Vivek Kavadi, Chief Radiation Oncology Officer of US Oncology, here with us today. Welcome to the show. We're very happy to have you.
Thank you for inviting me. Looking forward to chatting with both of you.
All right. Yeah, like Raj says, welcome to the Medical Muse podcast. So Dr. Kavadi, can you tell us a little bit about yourself? Where are you originally from?
Well, I was born in India. My family immigrated to the US when I was 5 years old and have grown up all across the country, lived in pretty much every part of the country and settled in Houston about 40 years ago. And so we've been here most of that time.
Okay. So you consider yourself a Texan at this point, or?
I think if you grow up everywhere, including New York and California and Kentucky and Texas, you become more of an American than just a Texan. But certainly Texas has been where I've lived most of my life.
All right. Well, it's good to have you on the show. Thanks.
Pleasure to be here.
So I know you moved around a lot. Grandfather was an architect. He was moving around a lot. Could you just describe how that was, moving from city to city, and how that experience was here in the US?
Well, it was certainly, challenging as a kid when you go to 4 high schools in 4 years in 3 states. I think that's probably a little bit more than most teenagers would want to do. But I think it was a great experience in the sense that you learn a lot about the country. The regions are certainly very, very different. New York and Houston are very different. The San Francisco Bay Area and Kentucky are very different. So got an opportunity to meet a variety of different types of people in different environments. So gave me a little bit more of a global experience, within the United States, and obviously a whole bunch of international travel and has enhanced that. But I thought overall it was a great learning experience, but certainly, challenging when you're a youngster.
How did you eventually end up becoming interested in medicine?
It was one of those things that when I was growing up, the space program was in its peak. Apollo missions were happening. There was a lot of buzz and excitement around that. So the very first career I wanted to have was to be an astronaut, but that lasted through 3rd grade. And in 4th grade, somewhere along the way, I shifted over to wanting to be a doctor. And from 4th grade onward to this day, that's been my passion, and I've never looked back.
Oh, wow. So yeah, you had an interest in medicine from a pretty early age.
So you went to Rice University for undergrad, and then you made your way to Harvard Medical School. Why don't you tell some of our audience about how your experience was at Harvard, and what are some of the biggest takeaways from that medical school experience for you?
Well, Rice and Harvard were very, very different places. Harvard, by its very nature, draws people from all over, and it had a heavy contingent of people from the Northeast, and a heavy contingent of people from Ivy League colleges. And having been a first-generation immigrant, having moved around as much as I had, so that was a bit of an adjustment. But certainly academically, it was an exhilarating place. I've been fortunate to have been in many great places in my life, but if there's a single place where I walked away impressed with the caliber of the talent, certainly Harvard Medical School was that.
And then after medical school, you did your residency at MD Anderson. Is that correct?
Yes. I was looking at a variety of different programs when I was in medical school, and was considering there were 2 Harvard programs at the time, and MD Anderson and UCSF, and those were my 4 finalists, and all outstanding programs, all fairly comparable in quality, but each with a distinct personality. And ultimately, I decided to come back home, and MD Anderson was my choice. Ended up being a very good choice. I had a great time and great training, and felt that my career was advanced just as well there as it would have been elsewhere.
That's wonderful. In terms of radiation oncology, medical schools don't always do the best job at educating students about the field of radiation oncology. Very few med schools have many classes about the field, and there aren't always opportunities to rotate in radiation oncology either. Could you tell us a little bit about the field for our audience, and uh, what made you interested in pursuing radiation oncology?
Sure, no, it's a great question. And if it's something that students don't have a lot of exposure to today, we had even less so 35 years ago. When I started medical school, my biggest area of interest was cardiovascular diseases. I was from Houston. Rice University is really right across the street from the Texas Medical Center. Denton Cooley and Michael DeBakey were in their absolute heyday at that time, and two of the leading heart institutions of the world were right across the street from Rice University. And I had the privilege of having spent one summer with Dr. Cooley and loved that experience being in the OR then. So when I came to medical school, my bias probably was to go into cardiac diseases. And when I got there, it certainly was of interest, but it wasn't necessarily narrowed down on that as my time in medical school progressed, and was really thinking through what I wanted to do in my third year, and did not have anything necessarily finalized. At Harvard, our third year was mostly required rotations, and radiation oncology certainly is not a required rotation. But we had a little bit of flexibility in terms of when to start our fourth year. I had an accidental connection with the field. My roommate, who I have known for a long time, had taken a year off to do research, and during that time found radiation oncology as a field. He happened to be a couple of years ahead of me and mentioned to me that I ought to look into this as a good option. And my exposure to oncology at that time really fundamentally was pathology, because that's what we learned in basic sciences. So initially, I wasn't necessarily all that interested, and went ahead and did a rotation. And two things happened during that rotation. One is that I had a phenomenal faculty mentor, a very prominent individual in the specialty, Dr. Jay Harris, who was a truly inspirational teacher. And the second thing that happened was I was fascinated by the field. I enjoyed the fact that oncology was an exciting and rapidly developing and innovative field. I enjoyed the fact that in radiation oncology, we treated the entire body. We treated a variety of cancers. We weren't necessarily subspecialized by an organ system. I liked the fact that it was quantitative. Math and hard sciences were areas of interest for me in college. I liked the fact that it was, in addition to being quantitative, there was some creativity involved for the physicians. And the fact that for the most part, the patients we see were patients that we could do something positive for. And sometimes in oncology, there's a concern that you have cases that may not be curative, and is there a situation in which you might necessarily get emotionally down because of the seriousness of the illness. But in radiation oncology, those concerns were mitigated by the fact that almost everybody we treat, we have a reasonable hope of helping. And ideally, we help them by enhancing their chance of cure. But even when we can't, the palliation is often quite effective. And so for all of those reasons, it was a very attractive career choice. And after a 1-month rotation at the end of my third year, I found that this was something that I could see myself doing. And frankly, over the last 30 plus years, I have never regretted this decision, and it's been a great choice for me.
Thank you so much for that answer. And if you don't mind just explaining to our audience, like what is radiation therapy? And if you could just describe the process of going from consult to simulation to treatment, and just basically how that works, because I don't think many people know about that.
Sure. Cancer, if you look at the disease globally, can be treated in several different ways. And those several different ways really fall into 3 large buckets. One is a surgical approach, and usually that is to remove the primary tumor, and occasionally the primary tumor and any draining lymphatics. The second is to do radiation. Radiation can be delivered to the primary tumor. It can be delivered to draining lymphatics. It can be delivered to metastatic sites. And then the third is systemic therapy. That's usually chemotherapy or hormonal treatment or immunotherapy. And those three broad buckets of care are how cancer patients are managed. And most of the time, patients will get some combination of these three. Sometimes they get only one of the three modalities. Often they get all three of them. And so radiation is one of these three broad buckets. The approach with radiation is to eradicate the disease locally or regionally. Radiation is given to a specific site, and that may be the tumor, it may be the lymphatics. It's not given to the entire body. So the process involves determining what your target is and determining what your avoidance tissues are. So ideally, you want to give as much radiation as possible to the tumor in order to maximize your chance of killing the tumor cells. And you want to give as minimal a dose as possible to normal tissues to reduce the risk of any toxicity or long-term side effects. So the process of radiation oncology is similar to other specialties in the sense that you see a new patient, you take a history and physical, you make an assessment of the patient's condition, you order the requisite tests. Usually in our field, it's imaging. Obviously, we do some lab work as well. And then you collect all those facts, the physical exam, the history, the imaging, the pathology from the biopsy, the laboratory work, and you come up with a stage. And that stage is how you categorize the risk that that patient has. And once you've made that judgment, you determine what the best course of action is for that patient and their condition and their stage of disease. After that has happened, and oftentimes that is in conjunction with collaborators in surgical oncology and medical oncology, you determine a sequence of treatments, and the radiation sequence then starts with a treatment planning procedure. And that is a procedure that we called, it's called simulation. And what we are doing then is we are simulating how the patient will be treated. We determine their position, we determine any immobilization. We gather an imaging data set, usually from a CT scan. And then from that CT scan, we target the organs that we want to treat. We target the organs that we want to avoid. And that determines the foundation of a subsequent treatment plan. That data is given to our physics and dosimetry professionals. They then put it into a software program and create an optimized treatment plan. The physician reviews that, and after approval, the patient then goes usually to a linear accelerator, and that treatment is delivered. So a little bit of a long-winded answer. I don't know if you wanted that much detail, but that's how the process works.
Yeah, that was wonderful. Thank you. Like Raj said before, in medical school, we don't always get the most detailed description of how radiation oncology actually works. So that was a good answer. Thank you. I have a question based on something that you said earlier. You said that radiation oncology can kind of give you, as a physician, the opportunity to kind of use your creativity. Can you elaborate on that a little bit?
Sure. So if you are looking at how to treat a patient, that you have options. Now, generally speaking, most patients will follow a protocol, and with years of experience, you determine your way of doing things, but you do have an opportunity to try different things, especially on the treatment planning side. And that allows you to look at different patient positions. It allows you to look at different treatment planning techniques, and it allows you to see if there are ways that you can further optimize the care of an individual patient. As the field is evolving, to be open and full candor, that creativity probably is a little bit less today than it may have been in the past. As the field evolves, we get more and more sophisticated, and that sophistication results in greater automation and greater software capabilities. So you start creating class solutions that have been optimized. So I would say that our ability to do different things has been enhanced, but in the process, we're probably a little bit less creative than may have been when I was in residency, where really you had to think through different solutions.
I think that's probably similar to a lot of different fields of medicine. As more research and more studies come out, we develop guidelines that, if it's clear cut something that is seen often in medicine, there's not necessarily always a need for creativity when we have a good answer. So it's probably common across the board.
And especially in technology intensive fields like radiation oncology. Technology continues to improve at a much faster pace. And that's a good thing. It results in greater accuracy and for patient benefit. There is a movement towards more artificial intelligence in what we do in radiation oncology. So I'll be curious to see how that develops as the two of you and your colleagues continue in your medical careers long after I've retired. I suspect the field will be very different 20 years from now than it is today.
Thank you for that. Very interesting. And do you mind speaking a little bit about the difference between academic and private practice when it comes to radiation oncology?
Sure. And what I would tell you is sometimes that looks like it's a binary choice, and it is likely very different than a binary choice. There are very many shades of academia, and there are very many shades of private practice. And I think those boundaries are probably more blurred than people may think. But let me give you kind of an extreme example of each, and then we can explore the middle. Academia, in its purest sense, is a practice in which the physician's role is threefold. One is to treat patients. Two is to train residents and fellows and medical students in some cases. And three, to perform research to advance the knowledge of the field and to advance the care of patients. That research can be basic science research or it can be clinical research. So there is a variety on the research front as well. And how you apportion your time amongst those three responsibilities is highly variable. And there are physicians that are in the lab almost exclusively and see patients a very small percentage of the time. And there are physicians that are primarily seeing patients that are hardly doing any research. And both of those scenarios can be in academia. And the nature of academia is highly dependent on different academic departments. Every institution has its own personality and its priorities. So there are significant variations in what an academic job looks like across the country and even within certain departments. In private practice, the focus is primarily on patient care. And that private practice can be in a hospital-based setting. It can be in a freestanding cancer center. And in some circumstances, that is a pretty run-of-the-mill bread and butter type cases, because those are the types of patients that particular setting sees. In some other circumstances, it could be in a much more sophisticated tertiary care hospital, where there are many specialists and really sophisticated tumor boards and multidisciplinary care. There could be specialization, and those private practitioners may be seeing only certain types of diseases. So there's a lot of variety there as well. And the third comment I would make is this. Academic centers are now expanding and forming kind of regional networks. And in those networks, they'll have a hub, which is the mothership, which may be where most of the academic work is done. And then there's satellite centers where a lot of the clinical work is done. And private practice, especially groups like ours, can be very big and can have multiple sites of service and can be doing a fair amount of research themselves. So we're one of the largest research organizations in the country. And so there is a great deal of overlap. I think what students ought to keep in mind is figure out what aspect of radiation oncology you enjoy being involved in, and then know that there are different ways of satisfying those interests, and don't get caught up necessarily in thinking that this is a binary choice, because it really isn't.
Amazing answer. Thank you so much for sharing that. And you were in academic medicine a little bit after residency at Anderson, and then you transitioned to US Oncology. which is a different world, and you took on a variety of leadership roles. Do you mind just sharing a little bit about your leadership opportunities within U.S. oncology and how that territory has been, being a physician first and then transitioning into that environment?
Well, I mentioned Dr. Harris, who was my mentor when I was in medical school, and when I interviewed for a position with him, I asked him, what is he looking for? And he said that we're looking for people that want to make a contribution, want people that want to be leaders. And sometimes as a student, you don't really know necessarily what that means. It's not like leadership is something that you are born with. It's something that often develops, your interests develop. I loved academia intellectually. I love the multidisciplinary environment. I love the tumor boards. I love the intellectual exchange with colleagues outside of radiation oncology. I liked and actually loved teaching residents. So all of those aspects of academia were great for me. The thing that I wasn't necessarily as inclined to do, and not that I was averse to it, but just wasn't necessarily my biggest interest, is that academia, especially at really high-powered places, there is a significant focus on productivity from a publications perspective. And even though it was an area that I was interested in, it really was not my primary focus. And my primary focus was clinical care. And so I decided to move into private practice. And when I went into private practice, I really thought that it was going to be about clinical care and nothing else. And when I took a job with Texas Oncology, really as I started, it was really only about clinical practice. But Texas Oncology is a very large organization, and large organizations create and present opportunities. And one of the opportunities that I had was to get involved in leadership. I came on the board very early on in my career, and that gave me some experience in how to manage a practice to contribute to a very large group. We then became part of U.S. Oncology, and was fortunate to have the opportunity to help create the radiation oncology division within U.S. Oncology, along with a handful of colleagues and friends. And next thing you know, we're building something quite large. And so we now have a practice with 140 cancer centers around the country, about 200 radiation oncologists. So I went from being a clinician in a small private practice by myself to being a chief medical officer for this division, which is 200 doctors and 140 cancer centers. Now, in many ways, there are parallels with running an academic department when you're part of a big organization. But this is a different focus than an academic department. But so I would say that in my case, those leadership opportunities kind of developed, and I wasn't necessarily on a path to become a leader, but when those opportunities came up, I gravitated towards them, and it's been pretty rewarding and fulfilling for me.
So I have a question for you. Sometimes when I look at different specialties, I have a background of kind of being interested in entrepreneurship. So I kind of imagine what different entrepreneurial opportunities might exist within a certain specialty. Are there any entrepreneurial opportunities that you see kind of take off in certain areas or of the country or anything with radiation oncology? Or is the barrier to entry kind of quite significant that prevents that? Or what do you see kind of in that atmosphere?
Well, U.S. Oncology and Texas Oncology prior to that really were entrepreneurial practices. So if you think through how radiation oncology is delivered, it is an extremely capital intensive specialty. There's significant upfront expense. There are significant expenses associated with running the department. We have highly skilled professionals that are necessarily core to the process and are often quite expensive. So you're talking about a field that requires a meaningful commitment of resources to build a proper department. So our group, and we're not the only ones, certainly, others have done this. Our group was entrepreneurial in the sense that to be able to offer this in the community in patients' neighborhoods, in areas that may not have had them previously, to offer care in an outpatient setting that previously may have been offered only in a hospital setting. And so we were entrepreneurial in creating those regional cancer centers that provided high quality multidisciplinary care close to the patient's homes. That was entrepreneurial. Then to link a whole bunch of those across the region and across the country to create a national network, that was entrepreneurial. So those are examples of what our group did. That's more of a group entrepreneurial perspective, not a solo entrepreneurial idea, because no one person can do these types of things. It's always a team. But there are also other entrepreneurial opportunities in radiation oncology. When you have a highly technical field, you have ideas to improve upon some technology, whether it be software or some device, medical device, or some other methodology of treatment. And many of the discoveries in our field have started with an entrepreneur who had an idea. And we have several of those today. We've got MR Linacs, we've got proton therapy machines, we've got a PET Linac machine. There are a lot of these types of entrepreneurial type opportunities. I think radiation oncology, because of its highly technical nature, probably presents more of these than the average.
So from my understanding, you recently went and received your MBA from Wharton. Is that correct?
It is correct.
So can you tell me a little bit about that experience and kind of what went into that decision and how that experience was for you?
Well, I mean, it was a great experience. I will tell you that I was the oldest person in my class. I was substantially older than the average student. The youngest people in my class were not too much older than Raj. So it was an interesting experience being in class with students that were closer to my children's age. I don't know. I mean, I think if I was to think through why I did it, there were probably three reasons why. One is that there was an intellectual itch. I had gotten to a stage of life where, as exciting as my job was and as much work as I was doing, at some point in everything in life, things become a little bit formulaic and maybe a little bit robotic. And so I needed something to kind of recharge the intellectual curiosity. And to do something in a field that I had no training in was a way of stretching myself. So I think that was one really, really important reason. The second was that I was already involved in a great deal of leadership and management types of jobs. And there are two lines of thought on this. People take the approach that you learn those skills on the job and you learn more and you perfect them and you continue to advance in your career, and that's fine. But there's a second line of thought, and that is that you get formal training. And I am, in that sense, much more traditional. I don't think that there is a true substitute for formal training. When you learn on the job, you learn what you're exposed to, but that doesn't necessarily mean you're exposed to everything. And formal training gives you exposure to a variety of things, and you never know when it comes in handy. And I think the process of learning, and frankly, in my mind, what intelligence is about, is taking pieces of information and taking learnings and deciding when and how to apply them in unknown situations. And formal learning, in my mind, facilitates that. So that was a second reason. And the third reason was frankly not quite as idealistic. I think when you're in the business world and you come with an MD, non-physicians sometimes don't take your management skills seriously. And to have a MBA, I think, was part of the reason, was to say, hey, listen, I put in the effort, put in the hours to learn your world. So, you can take that aspect of it a little bit more seriously. So those were the three reasons to go to business school. The experience was certainly exhilarating. It was challenging. Obviously, Wharton is a high-powered environment. I had not been in class in terms of a conventional school for over 30 years. I had not taken a standardized tests in nearly 30 years. To go back to school and to learn how to be a student a generation later when teaching is different, testing is different, and rubrics for grading are different, and all of these things was a huge transition. So there were definitely times in which I was like, well, what did I get myself into? I was working 90 hours a week, being a medical director, having 2 medical directorships, 2 sites of clinical practice, being a husband and a father of 3, and going to school. I can say with a great deal of certainty, when people say they don't know what the rubber band can be stretched to, those 2 years, that rubber band was at its maximum stretching. I don't think I could have done anything more in life. So it was a great experience, but now having done it, it's hard to imagine going back and doing it again.
I understand.
No, thank you for sharing all that. And I guess just in closing, 2-part question. What advice would you give to people who are interested in medicine? And in terms of radiation oncology, as you know, there's a little bit of a dip in the popularity at the moment. Why is this still an exciting field to be a part of? Why should students still be interested in radiation oncology?
Well, first off, in terms of medicine, what I would say is I am an unabashed promoter of the field. I think it is one of the most honorable things human beings can do in life, and that has not changed. Always know why you want to be a doctor, and then have the passion for it and go forward and do not look back. It's a phenomenal career choice, and I would not discourage anyone from going into medicine. And everything you hear about, I wouldn't advise my kids to do this. You'd never hear that from me. In terms of how to select a field, there are many parameters that go into that. And I don't know that there is a right way or a wrong way. And what I would say is you ought to consider all of the following parameters. Number one, and probably most importantly, do you really, really enjoy the day-to-day aspect of that job? And until you spend time doing something, it's nothing more than theoretical. I knew nothing about radiation oncology, and then I spent a month doing it, was inspired, went into residency, loved what I was learning, and have been in practice. And even though I'm a chief radiation oncology officer, I see patients 1 day a week. It's something that I really enjoy doing, and I would like to continue doing it. So you have to find that field that excites you and that you really enjoy doing every day. Secondly, you have to consider the lifestyle of the job. Some jobs are mostly or exclusively outpatient with regular hours. Some jobs are much more intense and acute with significant expectations on your personal time. Those are things you have to think through. The next thing is some people like the excitement of highly acute cases, and some people steer away from that. And that you got to figure out where your personality lies in that. Which part of the country do you want to live in? What type of environment do you want to be in? Some jobs are open to a variety of settings. Primary care is available pretty much everywhere in the country. Some specialties, it may be less so than that. All of those things you've got to think through. You got to think about your family situation and what's compatible with the rest of your family. And then once you do that, pick a field. If you don't know, do a general internship or a general residency to give yourself a little bit more time. And radiation oncology, I think, is a great field. Whenever you think about any specialty, there are always going to be ups and downs. There's always going to be innovation and new development that enhances something and diminishes something else. That always happens. In our field, as chemotherapy has gotten better, lymphoma treatment with radiation has gone down. When I was at MD Anderson and I was a faculty member there, I was a lymphoma attending. And I used to see a lot of lymphoma patients and treated them with radiation. In practice, I see a few, but nowhere near what I used to. So why is that? It's because chemotherapy has gotten better. And so those patients are often treated with chemotherapy. However, previously, metastatic patients were treated only for palliation of bone pain or palliation of brain metastases. Now we're doing a whole bunch of stereotactic radiation for what is a metastatic patient. Now that is something that we did not do previously. So here are examples in which the field evolved. One aspect of treatment went down and another aspect of treatment went up. When you have situations like advances in cardiac medicine, perhaps bypass surgeries aren't as frequent, but there are a whole bunch of interventional cardiology procedures now that are being done. So I would say that diseases rarely go away. How you manage them evolves. And as things evolve, there will be upswings, there will be downswings. I don't necessarily subscribe to the concept that radiation is somehow in a downswing. I don't think that's the case. And sometimes fears are overblown, but these things go in waves. If you're interested in radiation oncology, I feel pretty confident in saying that you can have a fulfilling career for most, if not all of your career. I don't see anything taking the specialty away, but the specialty will evolve. It's very different today than when I went into residency. And most of those differences are substantial improvements. So I wouldn't be discouraged by going into medicine, and I wouldn't be discouraged by going into oncology, and I wouldn't be discouraged about going into radiation oncology.
I have a quick question about that. So as you talked about how the field has kind of evolved and changed throughout your career, and then now as your career has been long and you're in leadership now, and probably looking at the field maybe from a step back, where do you see the field in the next, say, 3 years, 5 years, 10, 30, any type of years just in the future? Do you see it changing in any way, or where do you see the field going?
Well, the baby boomers are in that retirement phase and will continue to swell the retirement ranks. And cancer is mostly a disease of the elderly. And so there's going to be a tremendous demand for cancer professionals. And oncologists are going to have many, many patients to treat. The key principle in oncology is the maximum number of patients are cured when the three modalities are working in a collaborative way. And so I think the field will evolve in the sense that there will be more patients to treat, but how they are treated may be different. The chemotherapy to immunotherapy transition is happening in a significant way. The conversion of cancer into a chronic disease is happening in a significant way. The nature of radiation evolving from multi-fraction treatment over several weeks to what we call hypofractionation over a shorter period of time is certainly happening. More stereotactic treatments are happening. There is a trend towards adaptive therapy, and we certainly haven't gotten into that today, but that's a new area. PET-based treatments are a new area. So there are a lot of technology-driven changes, and there are a lot of biology-driven changes as we learn more about the molecular makeup of cancers and how to address them from that perspective.
Wonderful. This was all very informative, and we were very happy to have you on the show, and we really appreciate your time. Thank you so much for joining us.
Absolutely, really enjoyed it. Best of luck to both of you. I know that you are graduating soon, and I hope you match in your field of choice and in your location of choice. And best of luck to your colleagues. And if any of you have any questions about radiation oncology, feel free to reach out. Happy to exchange thoughts with you.
Thank you so much. We appreciate you being on the Medical Muse podcast, and this was definitely very informative for me, who didn't know much about radiation oncology before, and I'm sure Raj has probably had similar conversations with you and knows a little bit more than I do, but it was definitely an amazing conversation. Thank you.
The Medical Muse is produced by Timothy Crowe. Your hosts are Raj Kavadi and Daniel Epstein. Social media team is Anja von der Osten, Ava Sani, and Nisarg Shah. Music on the show by Foxy Music. For more information, check out foxymusic.com. For those interested in internal medicine, join us next episode where we explore the path to internal medicine with chief residents from Mount Sinai Medical Center in Miami. As always, we'd love to connect with you. Follow us on Instagram at _medical_muse. See you next time.